Inhaled antibiotics save lives, but only if compounded right. Tobramycin, Ceftazidime, Aztreonam. These aren't just names in a book. They're critical tools in the hands of clinical pharmacists battling resistant lung infections every day. In this ultimate guide, we're breaking down exactly how to compound these life-saving antibiotics for inhalation and nebulization. With real techniques, pro tips, cleanroom protocols, and dosing insights you won't find in textbooks. Whether you're a pharmacy student, a resident, or a seasoned sterile compounding pro, this is the video you'll wish you had years ago. Let's protect patients. Let's level up your prep. Let's compound with purpose. So, why do we go through the extra work to compound antibiotics for inhalation? Because when you're fighting tough respiratory infections, especially in conditions like cystic fibrosis, bronchiectasis, or ventilator-associated pneumonia, there's one golden rule. Get the drug exactly where it needs to go. Inhaled antibiotics deliver medication directly into the lungs, bypassing the bloodstream entirely. That means more action in the airways, less waiting, and a stronger punch against the pathogens living in the lungs. They kick in fast, with rapid local action right at the site of infection, instead of circulating systemically and hoping to reach the lungs. And because most of the drug stays in the respiratory tract, patients experience fewer systemic side effects, especially nephrotoxicity and GI upset, which we often see with IV antibiotics. Plus, inhalation achieves much higher local concentrations in the lungs than IV therapy ever could, sometimes up to 100 times greater. That's a game changer against biofilm-producing bugs like Pseudomonas aeruginosa. This approach is essential in managing chronic infections in cystic fibrosis, post-COVID bronchiectasis, and ventilator-associated pneumonia. It's also a lifeline in treating infections caused by multi-drug-resistant pathogens, where systemic options are running out. So no, this isn't just a niche pharmacy trick. Inhaled antibiotics are clinical lifelines. But to use them effectively, safely, and legally, they must be compounded with absolute precision. Next up, we dive into the sterile compounding protocols for Tobramycin, Ceftazidime, and Aztreonam. And trust me, you don't want to miss this. Alright, you know why inhaled antibiotics matter. Now, let's talk about how to compound them safely, correctly, and legally. When you're preparing medications to be inhaled directly into the lungs, there is zero margin for error. You're bypassing the gut, the liver, and all the natural filters. Rule number 1. Compound under USP 797 sterile conditions. USP 797 is your law. Inhaled medications must be compounded in an ISO Class 5 environment, inside a cleanroom that meets USP 797 standards. We're talking proper garbing, aseptic technique, HEPA-filtered airflow, the full sterile compounding protocol. If you're not in a cleanroom, you are not compounding for inhalation. You're creating a contamination risk. Rule number 2. Use only sterile water or 0.9% sodium chloride. Only use sterile water for injection or 0.9% preservative-free normal saline as your diluent. No tap water, no buffered eye drops, no shortcuts. Even small amounts of endotoxin or microbial contamination can trigger bronchospasm, fever, or serious pulmonary injury. Rule number 3. Adjust for pH and tonicity. The lungs are delicate. The pH of your solution should be between 4 and 7.5, just slightly acidic to neutral. Too low, and you risk coughing, irritation, or even bronchoconstriction. Too high, and you'll degrade the drug or damage airway tissue. And don't forget osmolarity. Your solution should be isotonic or near isotonic, aiming for about 300 milliosmoles per kilogram. Hypertonic solutions can cause cell swelling and lung edema, while hypertonic ones cause pain and mucus thickening. Rule number 4. Match nebulizer type to drug properties. Not all nebulizers are created equal. For most compounded antibiotics, jet nebulizers are your go-to. They generate particles between 1 to 5 microns, the perfect size for deep lung deposition. Ultrasonic and mesh devices may damage fragile antibiotics or change delivery rates, so check compatibility before use. Rule number 5. Refrigerate when required. 2 to 8 degrees Celsius. Finally, storage matters. Some inhaled antibiotics, like Tobramycin and Aztreonam, need to be stored cold. 2 to 8 degrees Celsius is the sweet spot. Improper storage can destroy potency or promote bacterial growth. Always follow the stability data and beyond use dating based on USP 797. So to recap, the golden rules of inhalation compounding. 1. Use a sterile cleanroom per USP 797. 2. Only sterile, preservative-free diluents. 3. pH between 4 and 7.5. 4. Near isotonic solutions that is approximately 300 milliosmoles per kilogram. 5. Jet nebulizers are preferred. And 6. Refrigerate when necessary. Follow these rules, and you're not just compounding. You're delivering precision therapy with safety and integrity. Now let's dive into one of the most widely used inhaled antibiotics in clinical pharmacy. Tobramycin. Used primarily in cystic fibrosis and bronchiectasis, Tobramycin is your frontline weapon against chronic Pseudomonas aeruginosa colonization. Its goal is to suppress bacterial load, improve lung function, and reduce exacerbation frequency, without the systemic toxicity of IV therapy. Step 1. Reconstitute 1.2 grams of tobramycin sulfate with 80 milliliters of sterile water for injection. This gives you a final concentration of 15 milligrams per milliliter. Step 2. Draw up 5 milliliters of this solution, which equals 300 milligrams of tobramycin, for each nebulization dose. Step 3. If this solution wasn't compounded in a certified cleanroom under USP 797 conditions, it must be passed through a 0.22 micron sterile filter before use. Never skip the sterile filtration step if you're unsure of the environmental sterility. The lungs are not forgiving. The final pH should be around 6 to 7, slightly acidic to neutral. This range is gentle on airway mucosa and supports drug stability. Store your final solution refrigerated between 2 to 8 degrees Celsius. Under proper conditions, tobramycin remains stable for up to 28 days, making it ideal for batch preparation. And here's a major safety point. Always label your vials clearly, with a high visibility warning, for inhalation only, not for intravenous use. Administering this preparation intravenously would be catastrophic. Labeling saves lives. So there you have it. The gold standard method for preparing nebulized tobramycin. It's one of the few antibiotics proven to improve lung function and quality of life in cystic fibrosis, but only when it's compounded with precision and care. Let's lock it all in with a quick reference breakdown for nebulized tobramycin, so you can master this in under 2 minutes. Final dose. Simple. 300 milligrams of tobramycin in 5 milliliters of solution. This is the standard nebulized dose used in cystic fibrosis protocols across the globe. Why 5 milliliters? Because it's small enough for efficient nebulization and still packs a powerful punch in the airways. Dosing frequency is twice daily, every 12 hours, for 28 days on treatment, followed by 28 days off. This on-off cycling isn't random. It's designed to prevent resistance development, reduce toxicity, and allow the lungs time to recover. Patients should complete the full 28-day course, even if they start feeling better halfway through. Now here's a key clinical tip. In chronic cystic fibrosis management, Tobramycin is often alternated with Aztreonam lysine. This month-on, month-off cycle, alternating between classes, helps target different bacterial resistance mechanisms and maintain long-term control over Pseudomonas infections. And this tip is non-negotiable. Always use preservative-free, sterile water or saline. Preservatives like benzyl alcohol or parabens can cause severe airway irritation, and in vulnerable patients, even bronchospasm or respiratory collapse. Double-check your diluents. Your patient's lungs are trusting you. Final word. Tobramycin isn't just a drug. It's a life-saving respiratory strategy. But its power lies in the details. Right dose, right schedule, right compounding technique. Now that you've got the quick reference, you're ready to prepare it like a pro. Let's move on to a powerhouse antibiotic used in inhalation therapy for multi-drug resistant gram-negative lung infections. Ceftazidime. Ceftazidime is a third-generation cephalosporin that's often overlooked, but in the right setting, it delivers serious results. Whether you're managing ventilator-associated pneumonia, bronchiectasis, or post-COVID chronic infections, this is a go-to inhaled option when IV access isn't ideal or systemic toxicity is a concern. Let's break it down, step by step. Start by reconstituting 1 gram of ceftazidime powder with 10 milliliters of sterile water for injection. This gives you a stock solution with a concentration of 100 milligrams per milliliter. Next, dilute the solution to a final concentration between 15 to 50 milligrams per milliliter, depending on your clinical target. Most protocols recommend 5 milliliters of final volume for nebulization. That's the sweet spot for effective lung delivery. The wider concentration range gives you flexibility. Just be sure the final dose matches the prescriber's intent. Step 3. pH optimization is optional. Here's a pro-compounding tip. Ceftazidime solutions can drop below pH 6 after reconstitution. If you're seeing irritation or patient complaints, consider gentle buffering to bring the pH closer to neutral, but only with approved buffers. Never use unvalidated buffers. Only apply this adjustment if your protocol allows and your pharmacy is equipped to monitor pH post-buffering. Step 4. Sterile filtration. If the preparation wasn't made in a certified ISO Class 5 environment, you must pass the final solution through a 0.22 micron sterile filter. This eliminates the risk of microbial contamination, especially critical in pulmonary administration. Your final pH target range should sit between 6 and 7.5. That's optimal for stability, lung tolerability, and preservation of ceftazidime's antibacterial activity. Refrigerate your final product between 2 to 8 degrees Celsius. Ceftazidime remains stable for 7 days when stored in sterile, airtight containers under refrigeration, perfect for short-term batch compounding. To recap, ceftazidime by nebulization offers a potent and targeted treatment for hard-to-reach lung infections. When compounded carefully and filtered properly, It provides localized action with minimal systemic exposure. Now that you've got the compounding steps down, let's go through some must-know clinical tips for inhaled ceftazidime that every pharmacist and clinician should have at their fingertips. First up, dosing. The typical nebulized dose of ceftazidime ranges from 250 to 500 milligrams, administered every 8 to 12 hours, depending on the severity of infection and the pathogen's resistance pattern. That's usually diluted into 5 ml sand delivered using a jet nebulizer. Always align the dose with patient-specific factors, like renal function, age, and disease state. Now here's something that trips up even seasoned compounders: that rotten egg smell. Totally normal. Ceftazidime contains sulfur, and when it's nebulized, it can release a distinct sulfur-like odor. Don't confuse this with degradation. It's not spoilage. It's chemistry. So reassure your patients if they ask. If anything, that smell tells you the drug is active. Next, absolutely no preservatives. Ever. Preservatives like benzyl alcohol, parabens, or even sorbic acid can cause severe bronchial irritation or hypersensitivity reactions when inhaled. Only use preservative-free sterile diluents and components in every step of the process. Check every label, every time. Here's a pro move. For patients with airflow obstruction, pre-treat with a bronchodilator like albuterol about 10 to 15 minutes before ceftazidime nebulization. Why? Because opening up the airways first allows for deeper penetration of the antibiotic, meaning better deposition, better outcomes. This technique can reduce cough, enhance drug delivery, and maximize therapeutic impact. So, dosing range, odor reassurance, preservative warnings, and bronchodilator synergy. These aren't just nice to knows. They're clinical game changers when it comes to inhaled ceftazidime. Master these tips, and your compounding isn't just accurate. It's powerful, patient-centered pharmacy. Coming up next, another inhaled hero, Aztreonam. Don't miss it. Next on our list is Aztreonam, a monobactam antibiotic that's become a cornerstone in inhaled therapy, especially for chronic Pseudomonas infections in cystic fibrosis patients. The branded form, Caiston, is FDA approved and comes pre-prepared. But let's be real, it's expensive, and access isn't always guaranteed. That's where sterile compounding steps in. Aztreonam can be safely and effectively compounded in-house for nebulization, when done under strict USP 797 guidelines. Step 1. Reconstitute 1 gram of Aztreonam powder with 10 milliliters of sterile water for injection. This gives you a 100 milligrams per milliliter solution, which is your base stock concentration. Step 2. Draw 75 milligrams. That's 0.75 milliliter of the stock solution, and dilute it in 2 to 4 milliliters total volume for nebulization. That final volume is just right for jet or mesh nebulizers, balancing effectiveness and patient comfort. If needed, dilute with 0.17% sodium chloride solution, not the typical 0.9%. That's because Aztreonam performs best in a mildly hypertonic environment, which enhances mucosal absorption and reduces irritation. This mirrors Caiston's proprietary diluent and improves lung deposition. Target pH. Keep it between 4.5 and 7.5. That's safe for pulmonary tissue and stable for Aztreonam's structure. Too acidic. Add sterile sodium bicarbonate buffer, but only if your pharmacy protocol and sterility workflow allow for pH adjustments. Refrigerate immediately. When properly compounded and stored at 2 to 8 degrees Celsius, Aztreonam remains stable for 7 full days. Use sterile amber vials to limit light exposure, and label with exact expiration and storage instructions. Aztreonam, when compounded correctly, provides precise targeting of resistant gram-negative organisms with minimal systemic exposure. Whether you're alternating it with Tobramycin in a cystic fibrosis treatment rotation, or using it solo for off-label pulmonary infections, sterile technique and accurate dosing are your keys to safe, effective therapy. Now that you know how to compound Aztreonam, let's go over the fast facts that will make or break your clinical success with this drug. Standard dose. That's 75 milligrams, 3 times a day, for 28 days straight. This regimen is FDA approved in the branded form, Caiston, and it's designed to aggressively suppress Pseudomonas colonization in the lungs, especially in cystic fibrosis. Make sure to space doses at least 4 hours apart for optimal coverage. Aztreonam is most effective when used in alternating month cycles with Tobramycin. That means 1 month of Tobramycin, then switch to Aztreonam the next month. This cycling strategy helps minimize resistance, maximize bacterial suppression, and reduce drug fatigue in long-term cystic fibrosis management. Never use preservatives. That can't be stressed enough. Inhaled Aztreonam must be compounded with preservative-free sterile components only. Why? Because preservatives like benzyl alcohol or parabens can trigger airway inflammation, bronchospasm, or worse, chemical pneumonitis. When in doubt, read your vial labels. Your patient's lungs depend on it. Here's your safety checkpoint. Always label the final product clearly. Inhalation use only. Not for IV. Not for IM. This may seem obvious, but medication errors happen more than you'd think, especially when the compound looks like a typical IV vial. And lastly, device compatibility matters. Caiston is designed for use with the Altera nebulizer, a specialized e-flow rapid delivery system that delivers medication in under 3 minutes. If you're compounding Aztreonam instead of using branded Caiston, always make sure your final product is compatible with the patient's device. Mesh nebulizers, like the Altera, require specific viscosity and particle size. Otherwise, delivery fails. Final takeaway: when using Aztreonam for inhalation, dose precisely, alternate intelligently, compound sterilely, and label clearly. It's not just another antibiotic. It's an advanced pulmonary strategy. And done right, it can transform chronic infection management in high-risk patients. Now let's talk about one of the most overlooked, but absolutely critical, pieces of inhalation therapy, the nebulizer device itself. It's not just about the drug, it's about how you deliver it. First up, jet nebulizers. These are the gold standard for most compounded antibiotics like Tobramycin, Ceftazidime, and Aztreonam. They use compressed air to turn liquid medication into a fine mist, producing particle sizes between 1 to 5 microns, ideal for deep lung deposition. They're widely available, cost-effective, and compatible with most sterile compounded solutions. Next, a big caution: avoid using ultrasonic nebulizers with certain antibiotics. These devices generate heat during operation, which can break down heat-sensitive drugs like Tobramycin or Aztreonam, potentially degrading the active compound before it reaches the lungs. If your patient's using one, they may be inhaling less drug than prescribed. Mesh nebulizers, like the Altera or e-flow, are fast, quiet, and convenient, but they're not always plug and play. These devices push medication through tiny vibrating mesh plates, creating precise aerosols, but they're sensitive to viscosity, pH, and particle size. Always consult manufacturer data or published studies before using them with compounded antibiotics. Some formulations may clog the mesh or alter delivery time. Here's the bottom line: devices matter. Even if two nebulizers look identical, their output rate, residual volume, and particle size distribution can vary, and that can change how much drug actually reaches the lungs. So make sure pharmacy, nursing, and patients are all on the same page about what device is being used, and how it impacts therapy. And here's the clinical gold standard: standardize your protocol. Use a consistent device, with a validated dose and diluent, for every inhaled antibiotic you compound. This minimizes variability, enhances bioavailability, and simplifies patient education. It also ensures safer and more effective delivery, every time. Final message: the drug may be sterile and potent, but if it's delivered through the wrong device, you could lose everything. Know your nebulizers, match them wisely, and educate your team and patients. Because in inhaled therapy, delivery is half the treatment. Sterile compounding doesn't stop at the drug. In fact, if your cleanroom game and documentation aren't flawless, nothing else matters. Let's break down the core essentials that guarantee safety, compliance, and accountability in inhalation compounding. First, batch records. These aren't just paperwork. They're your legal, clinical, and quality trail. For every compounded inhalation batch, you must record the drug name and lot number, compounding personnel identifications, exact preparation date and time, diluent used, final volume, concentration, and storage conditions. Think of it as your batch's birth certificate. Document everything. Next, BUDs, beyond use dates. USP 797 gives you the framework based on risk level and storage conditions, but to go further, you also need stability data from peer-reviewed sources or validated studies. For example, a low-risk sterile compound stored in a refrigerator. You might get 14 days. But Aztreonam or Tobramycin, backed by specific stability studies, may allow up to 28 days when refrigerated. Never assume. Always verify, and document the reference for your beyond use date. Thinking about batching inhaled doses ahead of time. Then sterility testing is non-negotiable. If you're extending beyond use dates beyond USP limits, you need to perform USP 71 sterility testing, which includes microbial culture using validated media and incubation. No testing, no extension. Period. Also document your testing results with each batch. Regulators will ask. Your technique in the cleanroom is just as important as what goes into the vial. You must be in full USP compliant PPE, sterile gown, gloves, mask, goggles or face shield, and hair and shoe covers. Work must be done inside an ISO 5 primary engineering control, like a laminar airflow hood or biological safety cabinet. Aseptic technique is everything. One false move can contaminate the batch. Always clean surfaces, minimize hand movement, and never block airflow. Last but not least, labeling. Clearly mark every compounded vial or syringe with a red or bold label that reads, "For inhalation use only, not for injection." This isn't optional. It's a critical safety measure to prevent catastrophic administration errors. Inhaled drugs may be preservative-free, pH-adjusted, and not systemically safe. Never let one end up in an IV line. Compounding for inhalation is high-stakes pharmacy. You're not just mixing medications. You're delivering life-saving therapy directly into the lungs of critically ill patients. Own the clean room, master the documentation, and uphold the highest standards, every single time. Let's take a moment to remember why all this matters. Inhaled antibiotics aren't just sterile vials on a tray. They're powerful tools that can transform lives. Clinical data is clear. Inhaled antibiotics like Tobramycin, Ceftazidime, and Aztreonam can 1. Reduce hospital admissions, 2. Improve baseline lung function, and 3. And slow the progression of chronic lung diseases like cystic fibrosis and non-cystic fibrosis bronchiectasis. That means more time at home, fewer emergency room visits, and less dependence on systemic therapies. These aren't just statistics. These are real kids, real patients, and real families who count on you to get it right. That 5 milliliter syringe you compound could be the reason a child makes it to school this month. Or why a teenager can finally join their soccer team again. Behind every vial is a life, with breath and hope. So the next time you're in the clean room, gowning up, disinfecting vials, calculating pH, or drawing up a sterile filter, remember this. You're not just compounding. You are changing lives. You are giving someone a breath they couldn't take yesterday. You are extending childhoods, protecting futures, and healing lungs. One dose at a time. And that, right there, is the real power of pharmacy. Better breathing starts with your hands. You've made it to the end of the ultimate guide to sterile compounding for inhalation, and now, let's lock in the key takeaways. Number 1. Always, and I mean always, use sterile technique. Cleanroom compounding isn't just a skill, it's a standard. Follow USP 797 aseptic practices without shortcuts. Every drop, every syringe, every vial must be treated like it's going directly into a vulnerable airway, because it is. Next, know your numbers. Each inhaled antibiotic has an optimal pH and osmolarity that ensures maximum lung tolerance and therapeutic effectiveness. For example, Tobramycin likes a pH around 6 to 7, while Ceftazidime may need buffering. If it's too acidic or too hypertonic, you risk bronchospasm, cough, or loss of efficacy. Third, match the drug to the right device. Jet nebulizers are your go-to, reliable and compatible with most antibiotics. But avoid ultrasonic nebulizers, and always check particle size data for mesh systems. Because even a perfectly compounded dose won't work if it never reaches the lungs. Next up, storage and labeling. Once compounded, most inhalation antibiotics need to be refrigerated at 2 to 8 degrees Celsius, protected from light, and clearly labeled. Always label. For inhalation use only, not for injection. This simple red label could prevent a fatal error. And finally, stay informed. Compounding is not a static skill. It's a science that evolves. So study your USP 797, know your clinical protocols, and refer to drug-specific literature regularly. Because what you know protects who you serve. Sterile inhalation compounding isn't just a pharmacy task. It's frontline therapy. Master the technique. Respect the protocol. Deliver the difference. Because with every accurately compounded dose, you're not just following guidelines. You're helping someone breathe easier. And there you have it. The complete, no-fluff guide to sterile compounding for inhaled antibiotics. From Tobramycin to Aztreonam, from technique to stability, you now have the tools to deliver therapy that's not just precise, but life-changing. If this helped you, smash that like button so more pharmacists and students can find this content. Subscribe right now for more clinical compounding videos. We've got next-level content on the way, from IV admixtures to pediatric dosing pearls. And drop a comment below. Tell us, which inhaled antibiotic do you compound most? Tobramycin, Ceftazidime, Aztreonam. Let's compare notes. Remember, every dose you compound isn't just a product. It's a breath of relief, a moment of hope, and a step toward healing. Thanks for watching. Stay sterile, stay sharp, and I'll see you in the next video.